Okay, chapter 33, care of the surgical patient. Hopefully I can make this not so painful. We'll see though. Okay, purposes of surgery. There's aesthetic surgery. That's also known as cosmetic surgery. May be performed to change or improve one's physical appearance. So we're talking breast augmentation, skin lifts, tummy tucks, things like that. We can also think of cosmetic surgery for like people that are, I don't want to say, but not maimed, but has injuries to their physical appearance. We could do cosmetic surgery for that also. Okay, maybe burns, maybe scars, things like that. And we can do purposes of surgery for cure, treat, or cure a disease. We might take out a cancerous tumor. We might do a colectomy, which is basically taking out bad bowel and sewing the good parts together. We can take cholecystectomy, so we can sit there and take a gallbladder out. And we can also do surgery to diagnose, and that's when we usually call like a thoracotomy or laparotomy. We're going in and seeing what's the problem. Is there something we need to take out? We don't know what's going on with the process. So we basically go in and do a search to figure out what's going on. We could do exploratory, which is again searching, diagnosis to figure out what's going on. Palliation alleviates symptoms and provides comfort, but does not necessarily cure the disease or heal the injury. That could be tumors. I have what you call SOD, which is sphincter of Oddi disorder. So I need to get an ERCP every so many years. And that ERCP goes and puts in a stent into my common bile duct, which is where the sphincter of Oddi is, and it stretches it. And then I'm in the hospital for 3 to 4 days, and then they'll take that stent out. It helps alleviate some of the symptoms that I get, but unfortunately it's not curing me. I wish they could just cut the darn thing out, but I don't know, there's some reason why they can't. Prevention, done to remove tissue before it becomes disease. We think of breast cancer. Breast cancer is very genetic. So if your mom or your grandma has it, then I would say there's a really, really good chance that you can have it. So women elect to have mastectomies before it can turn into breast cancer. That's the same thing with ovarian cancer. They might find some weird looking cells when they do your pap smear, and so before those weird looking cells turn into cancer, they will do a hysterectomy to get rid of it. And reconstruction. Surgery is done to repair an anatomical or congenital defect, and that's going back into that, back to the aesthetic surgery. Like I just saw a farmer pull up. And actually, what's funny is a lot of this anatomical surgery is done by plastic surgeons anyway. A farmer cut off his ear. It was a clean cut. I mean, never thought it would be that clean. So they turned around and sewed it back on. Supposedly it's working. Ear doesn't have very much blood flow, so it probably has a better chance to being, reconstructed better than something that has a lot of blood flow. Okay, another one that I was thinking of also with this corrective is cleft palates, which there's a lot of kids that are born with cleft palates and are unable to nurse because of that, or eat. So that is not only a congenital effect, but it's something that is life altering. Degrees of urgency. Now, elective surgery, it says improves quality of life. Any surgery that is voluntarily scheduled a week or more in advance. What's funny is you can call it elective surgery. A cardiac cath, we're going to go in and see if there's any anything wrong with the arteries that are surrounding the heart, they'll call that an elective surgery. It's more of a diagnostic, but we call it elective because of the fact that, hey, the patient said that yes, they wanted it and it's going to be scheduled in 2 weeks. Urgent surgery, surgery required that within 24 hours of diagnosis to prevent complications that may occur with waiting. When I think of surgery like that, acute appendicitis, will if it's really inflamed, we'll keep the person in the hospital, do a day of antibiotics before we go in and retrieve it. Okay, so surgery required 24 hours. I'd even say a CABG, a coronary artery bypass graft. They might come in, do their stress test, and we say, oh crap, you failed your stress test, so now you got to take your cardiac cath, and we see from your cardiac cath that you need a 3-vessel CABG. So we will schedule that within 24 hours. Emergency surgery, surgery that cannot be delayed and usually scheduled within 2 hours if it's even scheduled. A patient come in with a STEMI, which is an ST elevated MI, will come running through the ER door, and generally we will put 2 IVs in them, get them stabilized as much as we can, and then get them to the cath lab. Surgical settings do we have? Well, we have outpatient. It can be a standalone surgery center. We have one in Centralia. It's right across from the hospital. Those are coming up more and more often. They found it's cheaper to do a standalone surgery center than it is to go to the hospital. So you can have places that are standalone for spinal surgery. You know, that surgery, what's weird is it's surgery that they'll actually lay you supine, and they take out all your innards to get to that into the back for that spine, and it's done on a standalone surgery center. You just stay overnight. They have nurses that keep you overnight for that. So standalone usually is less invasive surgery, like rotator cuff surgeries or gallbladders and stuff like that. We could do it in a medical office. Certain procedures, maybe getting a mole removed, could be there. An ablation, a uterine ablation. We can also do vasectomies are done in doctor's office. They don't take you to the hospital to snip. They do it right in the doctor's office. Hospital outpatient surgery department, which every hospital basically has an outpatient surgery department. Usually they have 2. They have one that's considered like a same-day care, where you might get your not gallbladder, like you go for a heart cath or a bronch or, you know, something of that nature, and then they'll have the hospital outpatient surgery where you actually go into the surgical bay. So gallbladder, appendix, that kind of stuff. And then we do inpatient, requires hospitalization to stabilize. So basically in your major surgeries, like for my ERCP, I spent 3 nights, I think the last time. And that was because I'm more apt to get pancreatitis. So they keep you in the hospital till you're stabilized. CABGs are like that. If you have a really bad gallbladder, they'll do it for gallbladder too. If I'm missing anything, I don't think so. Okay, what do we care about with the pre-surgical assessment? Well, patient history, review of the systems. We're going to look at cardiovascular. Generally, anybody that's over the age of 40, before they have surgery, they'll get an EKG prior to going to surgery. They want to make sure everything's right with your heart. If it's a more invasive surgery, let's say, what would we say? Hysterectomy, or hysterectomy is a good one. Trying to think of anything else, like CABG, but generally you don't get an EKG because the fact that you're going to get a CABG. If you're going to have a lobectomy or anything like that, we're going to get an EKG beforehand. We might even do a stress test depending on how invasive that surgery is. We'll do a stress test to see how your old ticker's going. Respiratory function. Before we would do a CABG on the patient, we would have them go and do a what is it called? Pulmonary function test. We want to see, are you going to be easy to come off of sedation or off the ventilator, or are you going to need some more work? We want to see where you're exactly at. Central nervous system, of course, we want to make sure everything's working and everything's connected. So there's no surprises. Another thing for the central nervous system, it's important that we get a history or review the system if they're doing anything with arteries, because one of the main problems with when we're talking about arteries is that we would have a blood clot. The patient could stroke out or get a PE. So the only way we're going to know if they do stroke out is the fact that they move all four limbs, right? And they have their fine motor skills. Renal, we want to see how that renal is going to do. Patients like for cardiac caths, we can put a lot of dye in. We're going to be more careful if they have renal issues because we don't want to kill the kidneys anymore. Musculoskeletal, gastrointestinal, we just want to look to see if there's any abnormalities. Gastrointestinal, some patients, depending on your surgery, if you had a hysterectomy or you're getting a rectocele repair or anything like that, they're going to want everything out. So generally they give you mag citrate so that you're able to poop everything out. One of two reasons. One, if they're down there and they nick the bowel, they would rather it be a bowel that has no poop in it. And two, once you come out of surgery, you're going to be on meds, pain meds, and the last thing they want is for you to have a backup. They don't want you to be constipated. They don't want to turn around and have a bowel obstruction, so they want everything out first. What's going on with the endocrine? That's really important for the endocrine because of the fact that when we're talking about a thyroid issue or diabetes with the thyroid issue, what we don't want to do is have a thyroid storm coming down on us whenever we're going into surgery. We want the patient to be stable. So if they do have anything wrong with their thyroid, we can give them medication so that it doesn't peak or plummet while we're there. And that's the same thing with blood sugar. We want to make sure that their blood sugar is stable whenever we're working on them. And hematological. If you have, do you know what your hemoglobin is supposed to be? It's usually about 12 to 14. So we're going to look to see that we're going to do a CBC and see where their red hemoglobin is. If their hemoglobin's down like in the 7s, we probably want to give a unit of blood before we get there. Because the patient's not going to have enough blood for the oxygen to get where it needs to go, and if they lose any more blood, that might be a problem. We're going to do a physical examination. We're going to listen to the lungs. We're going to listen for carotid arteries. We're going to listen about everywhere so we know if there's going to be any kind of problems. Sound like a plan? Okay, what other things do we need for patient history? Well, I think we should also, if the patient knows what's going on, or they understand what the surgery is going to be. We might want to ask what other surgeries they've had. Is this the first surgery? Has it their 15th? Now you have to be patient with our patients because if you ask my mom if she had any kind of surgery, she'll say, no, I haven't had any surgeries. Well, she had 2 stents placed in her heart. I consider that a surgery. Any family history, especially when we're talking about malignant hypothermia, that's a trait that's carried down through the generations. And basically what happens when they have a medication called like succinate, which helps you relax when we're intubating you, what that succinate can do is bring on this malignant hypothermia, and that means that your blood temperature goes extremely high. We're talking 105, 107. It's a medical emergency. We have the medication in our hospitals, but you have to mix it right there at bedside to put it into the patient. It doesn't come from pharmacy. The powder comes from pharmacy, and it's up to the nurses to mix it and give it to them. Imagine if your temperature goes up to 105, 106, 107, what that does to the rest of the body. You're basically cooking is what you're doing. So we have to know these histories. We also have to understand any history that patients had that pertaining to surgeries. Do they stop breathing? Do they brady down? What exactly goes on? We definitely need to know the current medications that they have. That's including herbals and supplements. Some people sit there and don't tell you about the herbals and the supplements, but some of those herbals, I'm thinking of that black, I can't remember what it is. Black, I want to say gush gush, but it's not that. Um, it messes with a lot of things. Ephedra. Ephedra is considered a herbal, but it basically is homemade weed, or I'm sorry, homemade speed. It raises the heart rate and raises the blood pressure. So that's something we need to know. It's supposed to be outlawed, but they're getting everything from Mexico and Canada now. Um, any OTCs? Do they take ibuprofen every day? Do they take Tylenol every day? Do they take maybe Pepcid every day? We want to know everything about them. What do they totally take? Do they take a Marilax every day? Well, this might be something to know if they're going to be at your hospital for a couple of days. Um, do they have any allergies or intolerance? Remember, allergies and intolerance are two different things. Some people might tell you that they have an allergy to morphine because it makes them nauseous. Yeah, it's not really I would not call that an allergy. I would call that a expected side effect, because a lot of times we give people nausea medicine before we give them the morphine. So do they have any? And how about alcohol, drugs, or addiction? You realize you can drink one beer every day and for 5 years. And that one day you don't drink one beer, you can go into DTs. Okay, so it's important. Some people are closet drinkers. So you see them drinking 4 beers a day, but they're stable and they're doing what they do. If we bring them in the hospital and we take them away from that beer, they're going to go into DTs. Okay, and for us, it's easier just to give them a beer than it is to give them Ativan. So you might see on our MAR every once in a while, there could be a beer or it could be a shot. I had I had a patient that had, what was it called? They called it a vodka. Oh, it was vodka like elixir. Like elixir. It sounds like something I have to add to something to make it. But no, it was straight vodka. Um, Pharmacy sent it up in the tube system for our patient. Like I said, it's easier just to give them what they usually have. It doesn't have to be, if they're used to a 12 pack, well, you're going to give them only a couple during the day. But we'll put them on their trays so they can have it. Tobacco and nicotine. Again, what does tobacco and nicotine do? Well, it makes you constrict. So your arteries and your veins constrict. Um, we should know that. We need to know that because it's important that we know what's going on with all parts of your body. Not only that, but if you're a smoker, you might not get off the vent. We need to know if you're a smoker so we know how much oxygen you should have, or we should look for any complications. And for women, we're last menstruation. The last thing we want to do is cut into somebody and expose the baby into something they don't have. So a lot of times they'll ask for your last menstruation, and some places will ask you up until you're 55 years old. I mean, I think the only one that's pregnant at 54 is Gwen Stefani. Um, but it's in the rule book. You have to, when you turn 55 is when they're going to stop asking. Okay, what kind of testing we're going to do? Preoperative testing, we're going to do a complete blood cell count. Remember your CBC, it's going to have your white count, it's going to have your red blood count, it's going to be your hemoglobin. So we're going to see if you do have any kind of infection. If you have any kind of infection and we don't have to do the surgery, we're not going to. Urinalysis, we want to see how those kidneys are working. If you have any kind of infection down there, Because if we go into surgery and you have an infection, that's going to overwhelm your body. Your body is going to be going in 12 different ways. So we want to make sure that you don't have an infection. So urinalysis, we're going to check to see if you have a UTI. Electrocardiogram, talked about that a little bit earlier. We want to see how your ticker is going. Chest x-ray, another thing that we might check just to see if you have any residual. Maybe you have some history of CHF. We want to make sure that those lungs are clear. And then we're going to do an HCG test, which tests to see if you're pregnant or not. Let's see, anything else I have to do? It does not look like it. Okay, next. Preoperative patient teaching. Patients who receive good pre-op teaching tend to do better post-op and have a smoother, shorter recovery. So what are we going to teach them? Turn, cough, and deep breathe exercises. And why we're asking that. Instead of spirometry. How you do instead of spirometry. And the thing is, what we might do is we might have them breathe into one. Well, actually, they suck instead of spirometry. And we're going to see how high they get. So we know what their base is. So when they come out of surgery, maybe they're hitting 4,000, kind of high, but maybe they're hitting 4,000. Then we know that when they come out of surgery, they should be hitting 4,000. It shouldn't be any less than that. Stimulation of lower extremity circulation. So we're going to put in TEDs, and we can also do SCDs, which you see at the bottom. Very important because of the fact we don't want them to have blood clots. Anymore, we get them up as soon as we can, but we still should be vigilant and make sure they have their SCDs or TED hose, or they're up and walking so they don't get a blood clot. And post-operative pain and discomfort level, that's really important, and what they should expect. And when I say that is when folks go and have a CABG, they go right into ICU, and there is literally 12 different lines going to them to monitor, not only to monitor, but just to regulate their blood pressure, their breathing, their sedation, their pain control. They're not awake, but you can still feel pain. So we have all this on you, and you're vented. So having your family come in and look at you like that, or even you coming out of sedation, your chest is going to hurt. We just sat there and took a saw and sawed the opening your sternum so we can get to your heart. It's going to hurt like crap. Actually, crap doesn't hurt that bad. It's going to hurt like hell. So we're going to teach our patient about that. We're going to teach them that you are going to be uncomfortable. It's going to hurt, but we're going to manage your pain. Okay. Another thing is even what they should be eating afterwards. When we're talking about big surgeries, what's the one thing we want them to eat? What do you think? Yep, I heard it. You're right. It's protein. We want them to eat as much protein as they possibly can, because of the fact that they have a lot of healing to do. Okay. Preoperative teaching, information regarding pre-op preparations, what you're doing pre-op. People are moving around and it kind of gets confusing, so let's not leave the patients, since they are the number one reason why they're there, in the dark. What the patient can expect in OR, like there's some surgeries where you're supine, there's some surgeries where you're prone, your arms are out or your arms aren't out. You might have an art line in one in the IV. It's good to tell your patients what's going on. You're also going to tell them what you're going to do once you get into PACU. Generally, we don't stay long in PACU. We get you in PACU. We make sure that you're a little bit awake, and then we move you off into to your room to totally recover. The last surgery I had, I remember going into PACU, waking up in PACU, and I asked her what she was giving me, because she had a syringe and she told me she was giving me fentanyl. I'm like, okay, now stop. You can stop that nonsense, because I don't want it. I didn't like how fentanyl made me feel. But soon after that, I can't even tell you if my eyes were awake, and they had me going into my room before surgery and sitting in the chair. I don't know how they figured that out, that that's safe to do it, but they did it, and I did it with them. So you'll unpack you for a little bit. We're going to measure your blood pressure. We're going to watch it for any bleeding. And then once we feel you're stabilized, you go back into your room, whether it's an outpatient room or you're going back upstairs to your inpatient room. Actions the patient can take to help prevent medical complications, like doing your turn, cough, deep breathe, getting up and walking, decrease discomfort, using a pillow whenever you cough. Okay, that could be decrease discomfort. Shorten recovery time. We got to get them up and moving and optimize healing. Get them up, moving, walking, and then eating plenty of protein. Okay, next. Preoperative medications, anticholinergics. When you think of anticholinergics, you have to think of it's going to suck everything out of you. It's going to suck every the saying is you can't spit, you can't, I'm trying to think how it goes, spit, poop, or pee. Basically, I think of a raisin with anticholinergics. We do that for a couple reasons. A, we do anticholinergics so that it decreases your spit. So when you're in surgery, you're not swallowing a lot of your spit and causing you to have any nausea. Another reason for anticholinergics is that they don't want you to swallowing and having any kind of juices that's forming in your mouth to go down into your lungs. Antibiotics, there's several surgeries that you have to have 3 doses of antibiotics within the first 24 hours. So they'll do an antibiotic before you go to surgery, during your surgery, and then 6 hours after your surgery. And then antiemetics. You know, what's it going to do? Well, antiemetics basically make sure that you don't feel like nausea or vomiting. Some antibiotics are considered anticholinergics also. So it's a 1-2 deal. And there's all purposes and goals of pre-medication. Basically, we pre-medicate so that there's no post-surgical complications. Okay. Informed consent. So anytime you're doing any kind of invasive procedure, when we're talking about invasive, we're talking about something that possibly could kill them. An EKG doesn't need to be, you don't need a to sign for that. Cardiac cath, you need to sign for that. A bronch, you need to sign for that. So it really is something that can pretty much hurt the patient. Here we have Emma. You can't see it. Emma is her name, Emma May. Here's her patient number, date, and the time. And then we have the doctor. And then you have to hospital nursing student to perform upon, and that's her name again. And then what are we doing? We're doing a left total knee replacement. And then here's all the problems that could be because of the left knee replacement, and they always tell you right there, death. Let me see if I can. Yeah, shit. Me and my, okay, right here, death. Okay, that is something we put on all of ours. It doesn't matter if it's a colonoscopy, a bronch, it doesn't matter. We're going to put death on there because no surgery is routine. I've had patients that died during a colonoscopy. No fault of mine, they were down in the surgery area, but they did die because of a colonoscopy. And who thinks that they're going to die from a colonoscopy? Okay, then we have her sign. If it was not her, we're going to have somebody that's authorized, maybe her husband if she's incapacitated. Or we would, if she's unable to make those kind of decisions, we would call family and we would have the nurse sign and then a witness for that nurse. Then we have, depending on, it's not always witness to the signature. Um, and then we have the doctor's signature. The doctor has to sign his own consent. Okay. And this isn't letting me go. For some reason, it's not letting me go back to the last one, that pre-surgical checklist. But take a look at it. And the reason I want you to take a look at it, see what they came up with whenever we're talking about pre-surgical, before we start. We have the pre-surgical checklist, but they learned this actually from the airport or the airlines. Did you ever hear of a timeout? We perform a timeout before we start any procedure. The reason we do a timeout is that back in the 70s and the 80s, all the planes were falling out of the air. They're falling to the ground, and it was basically human error was most of it. Then they found out that, hey, if we would do a checklist and look at all the parts of the plane to make sure they're still working, maybe we won't have these airplanes falling from the sky. So they do that check. You might hear it on TV every once in a while. They'll say rudders check, this check. Well, that's what we do in the hospital now. So if we are, it could be anything from doing a central line to doing taking somebody's gallbladder out. We're going to do a timeout to make sure it's the same person, the same diagnosis. This has really helped in mistakes because in the past, I know there's a urologist running around Southern Illinois that took out the wrong kidney. Now, if they did their timeout and they all agreed, then they would know that, it was supposed to be the right kidney and he took out the good kidney. Why he couldn't tell the difference is beyond me. I would not go to him as a for anything. That's for sure. So, but we do that checklist. Just look at it. You don't have to memorize it, but just look at it. Okay. Surgical team members. Okay. We have anesthesia. Usually that's either a provider, that's either a doctor or it's a CRNA. I think there's more CRNAs around than there are doctors. The CRNAs basically are the ones who are with you whenever you are under anesthesia. Your doctors are ahead of all the anesthesiologists, and they're usually the ones that come in and do, check your teeth. Do you have any teeth that are loose? They look at your throat. They listen to your lungs just to see how you're going to do with anesthesia. And then the CRNAs are the ones that usually are the ones that put you to sleep. CRNAs think they're the cool cats in the hospital because not only they're nurses, but they, have the power of people's lives in their hands. They're very good at teaching. I do love all of our CNAs I ever had because, they really like to teach. Then we're going to have the surgeon. It may be an independent surgeon, or it's maybe a surgeon that is supplied by the hospital. What we call locum are surgeons that maybe our surgeons went on vacation. So we'll have a locum come down, and when I say come down, because they seem like they're always coming from Chicago, come down and work a week at our hospital. And then they might go home. They might be a locum for maybe a month. It all depends. We also, with that surgeon, we might have another doctor, or we can have a PA or a nurse that's serving as a first assistant. The assistants, they assist throughout the whole procedure. So they're controlling the hemostasis. They hand them instruments. They help manipulate the skin or the organs. They can do a cut. They can. Some first assistants look for, when we're doing cabbages, they look for veins that they can reroute that blood flow. When they close, they're the ones who close. They're the ones who staple or suture the patient closed. Circulating nurse, she is a nurse. Okay, she basically is the management of patient care. She circulates through all the different surgery suites that they have. She's the primary advocate for that patient. Okay, she's the boss lady or boss man. And then we have scrub nurses, and those are either nurses or the LPNs or their surgical techs, and they set up the sterile field and supplies and maintain sterility. That's their biggest job, is to maintain the sterility. Okay, preparation of the surgical suite. The room before the patient comes in has to make sure that it's ready for the patient. Okay, the procedure or appropriate equipment, it depends on the procedure. They know generally which doctors want what and when they want them. But their job is we have to make sure it's complete sterility. Then we do the surgical scrub, which is more in depth. They use the brushes to brush their nails. They go all the way up to their elbows. They use that brush to go all the way up to their elbows. And once they're done, they do not touch anything until they go into that surgical suite, and then somebody dresses them. They put the gown on, and then the surgical gown, and then they do the gosh, I can't talk. Do the gloves, keeping total sterility for the patient. Oh, I'm sorry. Didn't mean to do that. Okay, then there's a video that looks like they're going to do a timeout. I'm not going to do it now, or maybe I should, so you guys can see a timeout. We will do it. Then you might not even see it. I can't do it. So as you're playing with this, I'll probably just take this and put it up on a module so you can see a timeout. How's that? Sound like a plan? Oh, now it's going to go. But it's not. Let me see if I don't think you'll be able to see it. So I'm just going to my next. Okay, types of anesthesia, general anesthesia. That is when the patient is totally unconscious. This we need to secure an airway. Okay, so with general anesthesia, we have to secure an airway because everything is basically paralyzed. Okay, conscious sedation, the patient is asleep but not totally unconscious. You can ask them to move things, like, hey, won't you move over here? Usually when we're talking about conscious sedation, we're talking about they might be on Versed or Propofol. Propofol, the Michael Jackson milkshake drink that he liked. So things that the patient is asleep but not totally unconscious would be a EGD, a colonoscopy, a bronch. They're not totally asleep for that. A cystoscopy, which is basically putting a camera up your urethra. Although I think I'd want to be sedated for that. They don't sedate you for that. You can be under conscious sedation. So any of those that are not, they're not without their risks, but we don't have to do the whole down into general anesthesia. Okay. You are a little bit more stable with the conscious sedation. And then we do regional anesthesia, which blocks the nerves in a region. And when I think of that, I think of patients that are getting an epidural. Some patients get an epidural, other than for a baby, because maybe their lungs are too bad. So we don't put them under general anesthesia because we don't think their lungs can handle it. So we'll do a regional anesthesia for that. So that could be either a spinal or epidural, or we can what's called a nerve block, and they'll go into a certain part of the back and put some, I don't want to say anesthesia type medication, but it's basically what it is, and it numbs those certain areas. Then we can also do local anesthesia, and local anesthesia, it's very small tissue that we put some lidocaine in. Okay, maybe you're getting a mole taken off, so we're going to give you a little anesthesia right there. I think sometimes the darn lidocaine hurts more than the needle itself. But we still do it. We still give them lidocaine if they want it before we start IVs. Okay, intraoperative interventions, miscellaneous interventions and equipment, like cardiac monitoring, straps, they might strap you down, vital sign machine, vents, positioning of the patient. We want to make sure that it is the position that's most for the doctor to get the job done. We have to worry about the skin preparation, so we might have to shave them or wash it. We could do a chlorhexidine bath right there or betadine. We also, the surgical scrub goes along with that skin prep. Draping the patient, basically we isolate the area that we're going for. So if it was for a C-section, of course we're going to do it for the belly. If it's for, let's say, a compound fracture of the femur, we're going to put drapes all over, but leave that part that we're going to operate on the femur open. We should, when we do that timeout, we should have site markings of what site we're actually going to operate on. If it's the surgical procedure itself, we gotta know, is it endoscopic? Is it related to trauma? You know, what the surgical procedure is. Tissue specimens are usually samples or a biopsy of. And then final intraoperative interventions. Well, the last thing we're going to do is extubate the patient, document. We're going to give report to the PACU nurse, or if they're going right to ICU, or ICU nurse. We're going to clean up around, get everything cleaned up, and transport the instruments where it can be sterilized once again. Before the patient leaves the room, we're also going to count. So we're going to count all of our sponges, all of our equipment, to make sure that we don't leave anything in the patient. I'm sure you've heard stories about people, you know, them leaving instruments in the patient and how traumatic that was for the patient. And next one, if I can get my little thingy down there to hit the next slide. For some reason, it's not going. This is a professional. There we go. Okay. Descriptors that explain surgical: ectomy to remove, otomy to cut or separate, ostomy to create an opening, transplant to uproot and replant, and ablation to remove from. When you think of ablations, we're talking about uterine ablations. Some women have really heavy periods, so they'll do an ablation to get rid of all that tissue. So the oh dear Lord. So the uterus doesn't have that many blood products going on. We get rid of all that. An ablation also is for the heart. If there's multiple firings, the patient might keep on going into SVT, which is super ventricular rhythm. We'll do an ablation. If they keep on going into VTAC or VFib, we're going to figure out what nerve endings are making that heart to go like that. Okay, next. Okay, post-op care for the surgical patient. We're going to put them into PACU. And they're going to start transitioning you when you're in the OR to go to the PACU. There's some surgeries that they go right to ICU. They don't even go to PACU. They go right to ICU because they're critical. In the PACU, the RN will maintain close observation and assessment of the patient. They're only given so many patients so that they are right on top of those patients to make sure, because this is when the patient can't talk, so they can't tell you what's going on. You have to pay attention to those vitals and their assessments of the patients. This close patient observation and assessment continue until the patient is ready to transfer back to their room or home. So if it's a room upstairs or maybe their outpatient room, that's in the hospital. Return to the patient's room. We always give a report before the patient goes up to the room so they know what to expect. And by that time, they should have everything they need in the patient's room. It could be suction, it could be nasal cannula, it could be oxygen tree. So there's we have to make sure they have everything there in the room for when the patient. The one thing we don't want to happen is you bring the patient up and the nursing staff upstairs is like, what the heck is this? We weren't expecting you. We want to make sure we have everything involved. Initial post-operative patient assessment. That's the first thing you do. If you see the NCLEX that says, who should you see first? A patient that just came back from, let's say, an ablation, or should you go to that patient who's rating their pain a 3 out of 10, or possibly the patient that is doing their turn, cough, deep breathe, or maybe that patient that is diabetic and blood sugar is 92. Which patient should you see? Always pick the one that you need to assess first. Okay, we never ever bring a patient up from surgery and not to have a welcoming committee of the RN, at least the RN and the CNA. Okay, we need to see what that patient looks like before that OR team leaves. And that's because in case, are they looking gray? Are they looking blue? Is this how they look the whole time? We need to know that kind of stuff. And we're going to continue those assessments. Generally, when we're talking about the assessments, it's like we're going to do vitals every 15 minutes times 4, every half hour times 2, and then we go every 2 hours times 1, and then we're going to do every 4 hours after that. We're going to pay really good attention at those vital signs, because that's the first thing that we're going to notice is those vital signs when the patient starts deteriorating. Okay. Initial post-operative patient assessment. First priority, is airway. We're going to do vital signs, airway, how much oxygen, is the oxygen circulating through the body. The second priority is the level of consciousness, responsiveness, and what kind of cardiac rhythm are they having. So they'll probably still be sleepy, but you should be able to wake them up. Now, if you're talking about a CABG patient, a lobectomy patient that's going to ICU, of course they're not going to be waking up because of the fact they're going to be on a vent. But we're talking your gallbladders, possibly putting in a pacemaker, anything like that. We're going to see what their LOC is. We're going to look for bleeding and drainage. Okay. At this time, and when the patient first comes back and they have maybe bandages that are bloody, we're just going to reinforce, which means we're going to put another pad down, probably an ABD pad, and tape it to the patient. And if it's too much, then we're going to call the doctor. But we'd never take off that first dressing without an order. You just keep on. What do I want to say? We keep on. What is the word when you just keep on reassuring? It's not reassuring, but we just keep on building onto the original dressing. When we do put the dressing on, we're going to make sure we put our initials and the time and the date. Okay. At that time, we're also going to look at the drains. Do they have JP drains? Do they have I'm trying to think of any other drains. JP drains, are they hooked up to suction? Chest tubes, we're going to look at all that drainage and see what's going on. We're going to look at their IV site. Is it patent? Is the pump running? Do they have a Foley? Is there anything coming out of the Foley? Hopefully there's something coming out of the Foley. Then we're going to do a full pain assessment. Remember, just because if you're in ICU and you're dealing with a patient, just because they're vented and they are sedated does not mean they don't feel pain. They can still feel pain. Even when you're in surgery, they are giving you pain medicine. They're giving you fentanyl, they're giving you morphine, they're giving you something because your body still feels the pain. We're also going to make sure the rails are up, call light is nearby. If they need a bed alarm, they're going to have a bed alarm. Their head of bed is a little bit elevated, and they're going to have every supply we need for our patient. at bedside, and we're going to round on these folks. Okay. We don't want to put a patient in that just came from surgery and forget about them. We want to watch them. Post-surgical complications, a fever could happen because of the fact that it's infection. Atelectasis, that means that the lungs aren't totally working. They kind of I like to think of them as collapsing on themselves. Maybe you're not deep breathing because you're deep breathing, lungs saying, I don't have to be totally open. This is good enough for me. That's a problem. Okay, so we want them to deep breathe, turn, cough, and deep breathe. Pulmonary embolus can happen, and when we're talking about pulmonary embolus, usually it happens because of a DVT. Maybe we didn't have our SCDs on, maybe they're not up and walking. They can develop a blood clot in their legs, and then it can go right up into their heart and then into their lungs. Nausea and vomiting could happen. It's funny because sometimes nausea and vomiting, when Zofran is the number one that we usually give patients, but sometimes Zofran doesn't work. Then you might have to go to, I'm trying to think of the antiemetic, Thorazine. Thorazine's a good antiemetic. Reglan is also a good antiemetic, but I've had patients that went through all that promazine, Thorazine. They also went through Reglan, and nothing's working. Zofran's not working. And then all of a sudden, I remember the one doc said, "We'll give him some Protonix." Wouldn't you believe that worked? But it just seems like that one to get them over the hump. So they might come back nauseous and they're throwing up and they can't stop, and you're giving them medication after medication, nothing's working. And then all of a sudden you get that one drug, that one medication that works, and then they won't have nausea the rest of the time they're here. It's amazing. Urinary retention. We don't want to go be that nurse, and 12 hours after our patient comes back from surgery, we remember that they haven't voided. Okay, they have to void within 8 hours. If they don't void within 8 hours, you need to call the doc and see if we can't do a straight cap. Okay, or is it urinary retention, or is their kidneys not working? We got to figure that out. Wound infection, we want to make sure that we notice any signs or symptoms of infection. Dehiscence or evascuration. Dehiscence means that it's being pulled apart. You see that happen a lot of times in belly surgeries, especially if they have a big belly. We can see dehiscence. We don't want that to happen, so we'll do steri strips, or we'll do what we call Montgomery straps, which can hold both sides together. We're going to also give some teaching to our patient about nutrition, and that their immune system's a little bit off right now because we did, you figure the skin is the biggest organ, and we cut into the skin, so it's going haywire. The body's like, I got to fix everything. So we're going to, tell that to our patients, and we're going to make sure that we wash our hands and that we change the bandages that we're supposed to have. We want them to be as optimal as they possibly can. Okay, you sick of hearing me talking? Okay, well, let's go to the next one, and it is a clicker question. Which of the following is an example of an inpatient surgery? Surgery center, medical office, outpatient surgery department, or hospital-based surgery? Okay, we are talking about hospital-based surgery. Okay, now the one was, I can't remember what the one was, outpatient surgery department. Well, that's going to be outpatient. But when we're talking about hospital-based surgery, that is a lot of times those patients come right back into the hospital and they're admitted for at least overnight. Okay, next one. Clicker question. Which type of pre-medication might be used to decrease the risk of infection? Well, I know you want this on a test. If anybody got this wrong, antibiotics. Antibiotics prevent bacterial endocarditis in patients with a history of congenital rheumatic heart disease and valve disease with regurgitation. we're going to do antibiotics. I believe most surgeries are done with antibiotics, just in case. Okay, that's all I got for surgery. I hope you enjoyed our little talk, and I guess I'll talk to you later. See ya. Bye.